My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Paape,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
Hello, and welcome back to the Fix Podcast. So we have what I believe should be a very familiar face by now, but if not, shame on you. You're going to learn today. So right now we have Dr. Bernardo Nunes de Sousa in with us. So he is going to be, yes, and this time he's here in visual. You can actually see the man himself presenting, and he's a beautiful man. So we're really happy to actually have his face on the recording today. So welcome, Bernardo, and thank you for your patience with us as we still try to navigate global time zones. That's a very difficult thing for us.
It's true, man. Thanks for the invitation for the second time, actually. We had this recording. It was 1 year ago or 2 years ago. I don't remember. 1 year ago, maybe.
Yeah, probably a year and a half.
Probably, yeah. And
something like that.
Yeah, Soren was not on the conversation. It was just between us. Now we have a threesome, which is also fun.
That works as well.
Yeah. So it's been a very fast year, whole lot of developments. I definitely want to get into all the wonderful things that you're doing with Full Arch Club and all the new projects that you have in mind as well. But for those that don't know who you are and don't know about all the great things that you brought to our industry, would you mind just giving us a little bit of background about who you are, what your training's like, your journey to get up to this point, all the way back to dental school? Just give us that brief history. And this is something I really love hearing, because Bernardo has, throughout his career and his training and those who he's learned from, his mentors, it's very closely intertwined with the history of All in Four itself. He's really gotten to rub shoulders with such big names in Full Arch and what we do, and he's a big name himself. So really appreciate to hear that.
Yeah, so where did this start? It actually started, man, when I was 5. In my birthday, when I was 5, I said to someone that I wanted to be a dentist. And my parents actually have this on tape. I think I mentioned this in the last episode.
How cool is that?
Yeah. And then in Portugal, you do the primary school, then you do the high school, and then you go immediately to university. We don't have the college like you have in the US. So I went to dentistry and to the Catholic University. And the only thing I really cared about was the oral surgery part. I cared so much about that I could not study only the slides that we had to study for the exams. Each time I had an exam, I would read the whole goddamn Peterson book. I still, it's true, man. I still remember today. Actually, I have the book here. I still have, I wanted to show you, then the camera will. Anyway, I read the book maybe 10 times, man, during dental school. And at the end of, more or less in the middle of my dental degree, I saw this interview of Paulo Maló on the national television. And he was claiming to solving these very difficult cases within 1 hour surgery, very fast for the patient, with no grafts, no guides, because there were no guides back in those days, and always with immediate loading. And when I heard about this the first time, as I said, I was still in the dental school, I was very intrigued, because what we were being taught was maybe 6 implants, 6 to 8, double sinus lift or bone grafts and bone substitutes, then wait 6 months, 9 months with a removable denture, which is the worst thing in the world, especially on top of a graft. And then wait. He was avoiding this, and I was very curious about his technique. But it's maybe in the US is the same as it is in Portugal. Nepotism is universal, and you need to know someone that knows someone that will pull the strings for you if you want to work with a big name or in a very good clinic. And I was the first guy in my family to become a dentist, so I didn't know anyone. So I tried to pursue my postgraduate education to learn those things that Paulo Maló was talking about. So I went to the Netherlands. I did a 1-year post-graduation program. It was a residency in maxillofacial surgery. It was awesome, but it was not about implants. It was big maxillofacial surgery stuff, orthognatics, a lot of orthognatics, trauma, oncology cases, and that was not exactly what I was searching for. Also because I could not do these things then after that in Portugal for legal reasons. To do this in Europe, the legal part of maxillofacial surgery varies a lot from country to country. Even if you have a degree, even if you can do the maxillofacial residency as a dentist in one country, you move to another country that the dentist that will not be recognized. So I could not do that in Portugal, and it was not my goal. Was to do this rehabilitation with fixed teeth very fast, with minimally invasive stuff for the patient. So I did a 2 years master's degree in oral rehabilitation and implantology, and then I went to Cuba. And in Cuba, I stayed there about 6 months, and man, that thing, this time was so rudimentary. I don't know how it is today, but back in those days, doing a residency in surgery in Cuba, it's like you have one elevator, one forceps, and go ahead. And that was quite good, because you learn that all the fancy tools we have nowadays, man, they may help you here and there, but they are not the essential. You don't really need them. Maybe it helps you a bit, but it's technique. It's understanding, it's 3D visualization, is to work like a lever. It's not really about the tool. It's about yourself. And so yeah, but meanwhile, I was always sending my resume to Malo Clinic, but I never got a reply. But suddenly, that reply came, and they sent me an email. Actually, when I sent my resume this last time, it was a night out with my friends. I was a bit tipsy when I saw when I saw that they were recruiting for a clinic that was about to open in Paris. And at that point, with the right amount of alcohol, it was like, Paris can be nice. So I sent my resume without knowing what was going to happen. And and the guys, they called me, and I went to Lisbon, because I had to stay there for 1 or 2 years to do the whole training there. And it's quite nice, because the first day, nowadays I think it's not like that. And because Paulo Maló is not working at Malo Clinic anymore, there was some stuff going on there. I really don't want to go deep on that. But back in those days, when I entered Malo Clinic, Paulo Maló told me this: Bernardo, so what do you know about implants and oral rehabilitation? And I said, look, I did this post-graduation, this residency, this and that, blah, 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 blah. And he said, look, from now on, if you want to stay here, you forget all of that. Forget it didn't happen, because from here, we will teach you from zero. If you are okay with that, you stay with us. If you want to keep insisting on those old school kind of stuff, man, maybe this is not for you. And the guy was quite clear on that, and I enjoyed that. And
that's what they tell you when you start getting into like quantum physics. They're like, forget everything that you thought you knew. This is day one. You know nothing. That's pretty much how much of a revolution that is. Yeah.
And but he was right, and the guy was right. And my first day working at Malo Clinic was actually a quad zygo. Can you imagine? You get all these experience like bam from day zero. And so this was I would say the biggest part of my education. This was what actually changed my way of seeing things. My philosophy today has been very impacted from this experience, and maybe especially for the no bullshit approach. And something that we can talk later on, but something that I see nowadays, a lot of over-complications, over-engineering of cases when things can be done way more simplistic and with the same or better results. And in this kind of thinking, I think Paulo was way ahead, very far ahead of anyone in the implantology business, because you imagine what is doing an Alon 4 with tilted implants, with no grafts, with exposed threads in 2000. We are talking like 24 years ago, 25 years ago. Yeah. It was when he was already doing this. Yeah. And I was getting these cases there. I was watching not only the new ones, of course, but the follow-ups. And watching these cases that have 15 years follow-up, case after case after case. I mean, it's on the numbers, man. Who has the numbers has the reason. And so, So after this, I went to this big DSO. I was the head surgeon of their busiest clinic. I was doing revision cases, that cases that that failed, or cases that were about to go into the court, and they were trying to solve things. So I spent about 2 years only redoing cases, and that gave me a lot of not only endurance, but also, how can I say, to find bone when it doesn't exist anymore, and the pterygoid part, to tilt them towards the vomer, to the M variations, the transsinus, these things became necessary in this time. So that's when I started
creative approaches.
Say again?
I said creative approaches.
Yeah. More creative approaches. The palatal approach, I started it was, I would say that in 10 cases, maybe 7 or 8 were palatal approaches. And so I start, then after a while, you start to see your own follow-ups and say, this actually works. And maybe it works even better in some cases in terms of soft tissue. So yeah, and then after this, I work in several spots, getting cases, getting referrals, and then I created the Full Arch Club. And we were
history.
Yeah, man, the Full Arch Club was the first full arch education center in the world, and now there are a few more, but we were the first with these principles, with no grafts, no guides, no zygos, and no delays. And we had the pleasure to teach many people, including these two beautiful gentlemen here in front of me, who are amazing surgeons and who are now doing incredible work. You publish a lot, Soren, by the way. Tyler is more shy to publish.
I'm a recluse.
Yeah, man.
I talk about it a little bit on the podcast. I try to post almost every case that I do on my Instagram and challenges and just show the good cases, the beautiful ones. And it forces me to, when I require myself to post them, to really like make sure that I'm doing everything as perfect as possible. I want all my cases to be symmetric. I want efficiencies with my team, and I want to show everybody that follows me that's possible to do over and over again. And if you look at my cases over time, I actually recently just on my Instagram went back to all the cases I did this year and I highlighted them. So if you guys want to see all my cases, you can go back and see everything I've done this year. I was going to do like for all of my cases, and then I got to the beginning of this year, I was like, man, that's a lot. So we'll stick with just this year. And if you look at all of them, I mean, they all are basically the same approach. They all look basically the same. And I think that's what you want, right? You want all your cases to look the same because you want things to be efficient, to be repeatable. And that's where you see less complications, more efficiencies with your team.
I actually did a video, a reel, not that long time ago, that at some point it becomes boring. And it's true. It's always the same. If you have the process in your mind, it's like all the cases it's the same thing always. It's this kind of anesthesia, this kind of incision, this kind of flap, boom, all the way until the end. Maybe you have to do some variation here and there. Maybe instead of a tilted distal implant, it's a transsinus. Maybe it's tilted but more anterior, or it's small variations, but it's repeatable. That's why I said it at some point it becomes boring. I don't know if this has become boring for you yet, but I promise that it will.
I think what is boring just changes over time, right? Like you start taking on more and more trophic cases and borderline cases, and those might start to make you feel a little bit nervous from time to time. But then this stuff used to make you nervous. Maybe you don't even think twice about.
Maybe you even feel the need to start doing zygos just to get out of the boredom.
You wouldn't be. You're not far off from that.
This was a nasty one, but it was asking for it. So.
No, fair enough. Well, it's like you're always chasing that feeling. When I was down in, I'm skipping ahead a little bit, but when we were down in Brazil and we did the boot camp with you, I remember like I just felt so excited and a little bit nervous about going in and doing these like really advanced cases and a totally foreign environment, but the cases were incredible, and I was doing cases without looking at x-rays and building all this confidence and getting humbled the entire time, but like seeing great outcomes.
Man, if you tell this to the audience, man, I will have legal problems. You cannot say.
Oh, not at all. I mean, it was beautiful work. I stand by everything that happened. But you come back and now all of the cases are comparatively very easy, and you're starting to get that sort of, they all just feel pedestrian and normal and day to day, and you're looking for that feeling again because you get addicted to it. It's like, I don't know, the first time you go skydiving or jumping off a cliff, which you'll also do if you go do full arch club stuff. So you're looking for that kind of challenge.
It's true.
Always,
it's true. It becomes, at a certain point, what I found in my life was like, going to work was like going to the library. It's like I have to go there for a while, do some stuff.
Sure.
And as soon as I get out, I have another plans for my day. That stopped. This maybe many people won't understand what I'm saying, but the going to do a full arch case stopped being the interesting part of my day. I don't know if you relate with this, but
I understand.
I'm saying this very honestly. Like let's say, for example, I do a lot of referral cases. Mostly today, I go to some place and I do the full arch, and then I go out because it's done, and I don't have more appointments in that day. I just do that, and then I can leave. And usually my afternoons are the exciting and the difficult part, because I either go running, or I have a half marathon to do, or I go wakeboarding, things that actually scare me.
Yeah.
That was just a small part of my day, if this makes sense.
For sure. I think that resonates a lot with people that are just getting into full arch too. There's always this period where, you start and you're so excited about getting used to these cases and getting started with these cases. And it's like you're on this upswing where you're like, oh, you maybe have a couple that go really well. And you're like, these are great. I know what I'm doing. This is perfect. And then all of a sudden you have like your first couple really bad complications.
It's
and
the
like
Dunning-Kruger syndrome, man.
Yes, exactly.
Yeah.
You drop back
syndrome.
down.
Yeah.
And then you're down in this, you're in this pit, and it feels like a lot of anxiety when you go to work, and you're worried about the cases. But then you slowly, as you do more and more, you build it back up, and then it becomes a norm, and you're used to the complications, and you've seen a little bit of everything. And once you're back up to the top, that's when you get to coast, right? Yeah. That's when it feels like you're at the library. But it does take a couple of these cycles to get through that, to get to where you're confident. And Tyler and I have trained a lot of doctors here in the U.S., and we've seen a lot of these people, get up and they're really excited, and then all of a sudden they're down in that pit and they just can't get out of it, and they just don't. There's too much anxiety around the cases. But the fact of the matter is, if you keep challenging yourself, going to work, doing these cases, managing your complications, then you'll finally get to the point where you feel like it's rudimentary.
Exactly. And
I agree.
Let me ask you, let's invert who is the interviewer here for a moment. If I remember correctly, when you took the master course at different times, I believe, right?
Mm-hmm. Yeah.
You were just starting full arch, right?
We were probably I would say, Tyler was maybe a year and a half in. I was like 8 months in.
I was a year.
8 months.
Yeah.
Okay. And then,
so we probably had 50 to 100 arches under our belt, but fairly new.
Yeah. And then after, I guess my question is, how did your full arch life change after the bootcamp, after the full arch club curriculum, the master course and the bootcamp? Because I follow your cases, and guys, you are rock stars now, from what I can see.
Yeah.
And I'm curious to hear how impactful or not it was on your journey.
Yeah, absolutely. Well, just a little bit of background, just so the audience is aware. Tyler and I both did Bernardo's Full Arch Club Master course in Portugal, and I don't know, do you not offer that anymore? It's just all in the boot camp.
No,
correct?
We do offer.
Oh,
yes, yeah. So it's the main course actually. Yeah.
Yeah, so the master course was great. We went to Portugal, got to see Bernardo do surgeries, learned a ton, and then we went on to the second course in Brazil, where we got to do a lot more hands-on stuff. And I would say after the master course, where we weren't doing it necessarily on patients, but we got to do it on models and see the efficiencies in your office and the different techniques that you recommended, I was able to do so many more cases because I was able to see the extent of what was possible with traditional all-on-4. I feel like a lot of people get these cases and they're like, oh, that's a zygo case. Like, there's no way I can do that case. And the reality is there's a lot of these cases that can be done that walk in your clinic, and they can be done predictably using some of these workflows. And it's a lot less trauma to the patients when you're not doing these quad zygos or whatever you think that patient needs. And I was able to treat a ton of patients that I otherwise thought I wasn't able to. And I've seen these patients for follow-ups, and I'd be amazed of how well some of these patients healed that I previously thought there was not a chance that this is something that I could do, or that anybody without like experience doing zygotes was able to do. And my patients were so grateful that I could provide that service to them at, you know, the fee, because when you start getting into zygotes, all of a sudden patients are paying double what they would have for a traditional all-on-4, and you're able to save those anatomical landmarks for if something occurs 5 years down the line, not at that time.
Exactly.
So that's what I think out of that course.
Yeah, I think for me before the course, I probably referred out, I'd say as much as at least 5, but as much as 10% of the people who had terminal dentition and they needed something due to atrophic bone or what I thought would need zygotes and things like that. That number dropped to what I believe would be less than 1% at this point in terms of what I can,
less than 1% is amazing, man.
I believe that. I mean, it's a made-up statistic. I don't know how to show it.
But we have a feeling on, a feeling on that.
Right. And so, like, when I was doing just traditional all-in-4, I felt like I was the person that when patients were told no, or they had to get all these sinus lifts and things like that, I am the solution for those people. Now I feel like I can be the solution for people who have already had all-in-4 done.
Yeah.
And now they're being told that it can't be treated, or
now you are entering the library, man.
Yeah, that's right. That's right. So you're just in a different, you're like later on in that progression of the extremity of cases, and teach someone who was already doing all-in-4 how to do something next level or fix something that happened. And it made me competent in fixing my own problems, right? Yeah. Like I used to be just terrified if one of my distal tilted implants failed. Because I was like, well, that's all I know how to do. So now I'm going to have to graft and wait and come back and do this all over again. And now I know that I can revise this competently, and I almost get excited about it because I'm like, okay, cool. Like I can employ this now to fix it. So yeah, it was just that next tier of provider, and there's just all these more problems that you know how to solve. And now there's new problems too, but it's all recursive as you continue to progress. And Bootcamp was absolutely the biggest catalyst for me to get to that part.
And I also want to point out too that a lot of my philosophies have changed since the master course. Before, when I thought like traditional all-in-4 was the way to go for every case, now I see all the advantages prosthetically of what you can achieve when you're doing things like pterygoids. Relay those to my patients because I see a lot of patients that come from other clinics that are getting standard all-in-4, and maybe a couple of those distal implants failed, and the way that those surgeons will try to relieve that is placing new ones but more anterior. And all of a sudden you're stuck with a prosthetic that has a 3-tooth cantilever, and it's just not a good prosthetically driven approach. I relay that to my patients and I say, hey, there's a lot of other clinics here that'll do this. However, if you come here, we try to do more than 4 implants when we're able to place pterygoids and create a prosthetic that'll last you a long time. And if any of these anterior implants fail, we still have that posterior support, so we can relieve those issues much easier and with more predictability.
The anterior area is never a problem. Losing 1 or 2 on the anteriors, first, it's so rare that we don't even think about it. I don't even remember the last time I lost an anterior one. But when we do, it's so easy to solve. You have the nasopalatine canal. You can tilt them towards the vomer or towards the nasal crest or you have so many options. It's in the same spot, actually. You can just put a larger one. I mean, it's never a problem.
Yeah, absolutely.
But guys, you are rocking this. But you were saying something very interesting, Soren, because after integration, what really matters is soft tissue and cantilever. It's the 2 things that will dictate the future of that implant if we take out the systemic factors of the equation. If we take these out, it's soft tissue quality, keratinized band, and no cantilever. That's what we know from the literature, and that's what we see clinically, like you were saying. That's what will dictate if the implants will last longer, and if we will not have too much bone loss because of unnecessary trauma on the implant. And that's it. And pterygoids changed my life. When I started doing them in 2018, guys, I was taking the panoramic x-rays, and then I was looking at the result, taking a picture with the phone and deleting them. I had to hide this stuff Because in 2018, if you put 24 millimeter implants all the way back there, here in Portugal, man, the people would tell I was completely nuts. So hype these ones.
And now it's funny how fast stuff can become the norm, right?
True.
They see more and more cases. They see literature about it, and now, like, if you're not doing pterygoid implants, you're missing out on a lot of cases that you can solve much better for the patients that you treat. And it's funny because I see a lot of clinics here in Denver that have been around for 10 years, and the surgeons there, they've gotten comfortable with their standard all-on-4 approach. And some of these patients come to me because they're so frustrated with the fact that a couple of their implants failed and they've been in a denture for 2 years because they're just waiting for their grafts to heal. And I'm like, this is something I could solve tomorrow for you. Yeah. And it's with just taking the proper education to better yourself. And I think that's important for your patients when you're doing treatment like this.
Yeah.
So I think Bernardo, before we start talking about maybe some of these individual cases, and I know that you wanted to show some cases and stuff, I think you should let the audience know what the Full Arch Club concept is and how it's progressed over time and what they can expect if they want this education, and what your course looks like.
Yeah. So at the Full Arch Club, the pillars and the foundations of our concept is, as I said, no grafts, no guides, no zygos, and no delays. So I had a big contact with other approaches, for example, with zygomatic implants. And at some point, and I did a lot of them in the past, but at some point I had contact with another philosophy, which was the custom implants, aka the superiosteal implants. And this changed my mind to such a point that I started to cook an idea and a treatment protocol that would allow any doctor with the right mindset and with the right knowledge to solve any case without these things, without grafts, without zygos, without delays, and with immediate loading. And we have placed together a bunch of techniques, which are the All-on-4, the All-on-X, transsinus, transnasal, pterygoids, and the palatal approach. And what I found in my own experience is that if you only have the All-on-4 or the standard All-on-X in your tool belt, you will solve about 60 to 70% of all the cases. If you want to go from this 60 to 70% to the 95%, you need the palatal approach. Especially the palatal approach is the biggest thing that will change your game. The rest, the other 5%, because we are on the 95% now, the rest, you have the transsinus, the transnasal, the pterygoids, and the custom implants. And I found that with the combination of these techniques and the application of these techniques in the right case, it's not to apply it because yes. For example, when I started teaching the transsinus approach, and I saw many colleagues start to apply it in cases that they were not necessary, in cases that it was more than okay to do the standard All-on-4 and two pterygoids in the back. So this is the kind of the wrong mindset that I try to fight, which is why are you overcomplicating when you can be more predictable, reduce the morbidity of your case, and achieve the exact same result. There is no point on doing a transsinus if you can do a pterygoid. And yeah, so we found that with all these techniques, man, it is impossible that a patient comes to your office and you have no answer for them. So we created the master course to teach all of these things. I teach you all the fundamentals of full arch, of incisions, of flaps, bone reduction, the techniques themselves, suture, medication, follow-up. We teach all of these, and the students get to watch me and the other mentor, Dr. Pedro, to do this live surgery. And then, for the colleagues who want the ultimate experience, like yourselves, you go to our live surgery bootcamp in Brazil, where you will have the hardest week of your life in oral surgery, but maybe the best as well. And you will apply all of these things into patients in very difficult cases, the cases that, according to Tyler, he said this on the interview, cases you wouldn't even bother to flap. You remember saying?
Yeah, that's right. That's right. I remember saying it. Yeah.
And and after the boot camp, really, honestly, I think people are ready to tackle everything, and that's the feedback we have. We see these in our students. I see these on you, for example. You are killing all these very hard cases that I follow on social media, and other participants as well. So I feel like what I feel is like I felt the need to create these things because in my mind the full arch was not being approached the right way. I was seeing a lot of unnecessary stuff and unnecessary grafts and unnecessary zygos. I still see a lot of unnecessary zygomatic implants, to be honest, more and more. But I think that in the future things will change. I think the custom solutions for patients, and I'm not talking about custom implants, I mean custom solutions in general will be the future. I don't think that dental implants will be the future. I think the future of oral rehabilitation will be a true regeneration of what is lost and not fake stuff, not metal screws on the mouth. I think we will replace a lost maxilla by another maxilla. I think we will replace a lost tooth by a real tooth. The Japanese or the Chinese are already doing this. I published this news. It wasn't on the newspaper. It's on my Instagram. If you go there, that they were already successful on making a new tooth grow. And so I think it's a matter of fine-tuning now. For example, for partial dentalism, it's a matter of fine-tuning genetics to make the tooth with the right shape to appear in the right place, in the right position. If we get this right, I think dental implants will be obsolete. I think dental implants will be obsolete in the next 50 years. 50, not 15. I mean 50.
Yeah. I was about to say, hey, now starting to talk about our careers.
No. But meanwhile, we have a lot of patients to treat, and I do believe that these patients are way better treated with the techniques that we explore in the course compared with the old school alternatives, if I can put it this way.
Mm-hmm. Yeah, no, I totally agree. How would you say throughout the progression of Full Arch Club, like you've had to teach, I mean, you've taught so many people, there's so many cases behind this. Would you say that the philosophy of Full Arch Club has changed much at all? Or have you thrown in some more concepts that you feel as you've gone along the way that you've learned better ways to teach people? And you talk about soft tissue as well. Like what sort of things have gotten incorporated into the philosophy as you've gone along?
In the first editions of the course, we were not teaching soft tissue. And I never thought it was something that so many people were interested in or that wanted that needed that teaching. Because for me, the soft tissue grafting is part of my life since the very beginning. The free gingival grafts, connective tissue grafts, and I don't know, I've been doing that since in the dental school, actually. So it was routine. And then I found that many implantologists that can be actually great at placing the implants themselves, the soft tissue was missing, and the colleagues started to ask, Bernardo, can you explain the free gingival graft and this and that? And then I said, well, maybe we should introduce a lecture on this. So now we have soft tissue lectures on the master course as well. In the bootcamp in Brazil, if the case needs, we do soft tissue augmentation as well in a full arch case, usually in the same act. So we do for example, a full arch in the mandible that has this minimum keratinized band, and we increase with connective tissue graft in the same day. We are finishing our protocol for soft tissue grafting on custom superiosteal implants, which doesn't exist yet, and we already have it. How can I say? It's cleared for us. So when you do one sub, you also do this in the same day. And you get the tissue from here, and you put it this way and this way. We will release this soon, but I don't think that we have changed like the protocol in the implant part in any aspect. To be honest, Tyler, I think the concept, on the opposite, it only gets stronger and with more and more evidence. And now it's not only from me; it's also from you and from all the people that have taken the course. And I also see people that took our course and now teaching their own course with these principles. Yeah. So it's because it works, man. Because if it didn't,
it stood the test of time. Yeah, for sure.
Yeah, I think soft tissue management is something that is overlooked quite a bit and
Oh, yeah.
it's very critical. We've talked about this on the podcast before, but the best time to solve these soft tissue issues, and once you've seen enough cases and you've done enough cases, you can be pretty certain when you place an implant and you're going to do all of your during if that implant is going to have enough keratinized tissue around it or not. And if it isn't, there's a lot of people who are like, they just want to get done with the case and they're like, all right, let me just suture this up and send the patient home. But the reality is the patient's going to have a much better experience if you take that extra 10, 15 minutes to lay your pedicle flap to ensure the stability of that implant over time. And it's much while that flap's already done in the beginning of the surgery than waiting 2 years until the patient comes in for that follow-up, and you're sitting there with an implant that has maybe end of keratinized tissue on the palatal, but there's absolutely in the buccal, and you're starting to see some bone loss and some thread exposure, and all of a sudden you're in a situation that could have been so much easily fixed in that initial surgery. And that's something that we've talked about with like Damon on our podcast, and he stresses how much before he could do arches in 30 minutes and he would do cases in 30 minutes. And now it takes him maybe an hour to do an arch. However, he's being much more critical about that soft tissue because he's seen the complications that can occur if you're not. And that's just part of that progression through full arch. And part of our goal with this podcast is to help people prevent those issues prior to seeing them in 2-3 years and really focus on doing them right off the bat. So what Bernardo's saying about soft tissue management is critical, and learning that at a course like Full Arch Club, where you can go learn palatal approach, learn some of these other implant techniques, but then also improve just your traditional all-in-4 through soft tissue manipulation concepts is really critical.
And I think it's so easy, man, that it's a pity that we don't take the advantage of having our hands on the stuff and doing it at the spot, like you said. And but you know what I found with the years? When I started to get to the 5-year follow-ups, when I started to get my first 5-year follow-ups, I always photograph all my cases. And I was seeing some cases without keratinized tissue that I was absolutely sure that they had good tissue 5 years ago. So I went to see the pictures, and I was like, why did this happen? And you know what I realized with time and with talking also with people that started when I started, and people that were able to follow their cases for so long, because it's quite difficult to follow cases to 5 years or more. And everybody was having the same issues. Cases that have good tissue on the day, have good tissue on 1 year mark, maybe at 2 years mark, but after that, man, you start to lose keratinized band. And this is something that you will see more and more when you go close to the 5-year mark. Cases that were perfect are not perfect anymore. So the need for revision for soft tissue is a certainty. It is not a possibility. It's a certainty if you give it enough time. And it's something that I changed in my informed consent. Now it says that it will be needed in the future, maybe some kind of soft tissue improvement, because you will lose it naturally with time.
Yeah, absolutely. I think that that's something that here in the U.S., and maybe you see it in Portugal too, but there's a lot of clinics here and there's a lot of people practicing full arch dentistry that tell patients, hey, if you come to me, it's one surgery and you're done. Like, you'll be set for the rest of your life. And the reality is then when a revision comes in the future, it's so much harder to get that patient to agree to do a simple procedure like a pedicle graft, just to increase the longevity of that implant, because in the beginning they were told, hey, you won't need anything like this off the bat. So I think lowering those patients' expectations from the beginning and ensuring that they understand that, hey, you're 45 years old and you're in a place where you need a full arch treatment, there's a really good chance that you're going to need not only one revision, but perhaps multiple revisions throughout the rest of your life if you want this to last 40, 50 years. And it's that clinician's responsibility, I think, to learn these techniques so when that occurs, they're able to manage those complications. Oral surgeon.
Sorry. Go ahead.
I was just going to say, every oral surgeon that I've talked to here in the U.S. that I've asked them their opinion on should, general dentists be doing cases like this, Most of them, if they're not super conservative with their thinking, say, I don't care what a general dentist does as long as they're able to manage those complications that occur from those surgeries. And basic soft tissue management is definitely one of those complications that anybody practicing this style of dentistry should be comfortable with.
Yeah, we can never promise lifetime results. Look, the multi-center studies, which are those who I enjoy reading the most because they are studies done in a bunch of clinics in a certain location, and they reflect better the real-world scenario, the real-world results of the things that we do. And these multi-center studies show that the dental implants, after 15 years or more, only 2/3 are there. Only 2/3 survive the 15-plus year mark, which is something that I feel like not only patients don't know this, but doctors don't know this as well. And this is the harsh reality. The things that we are doing right now, man, if you have the luck, the blessing to be able to follow the case for 15 or 20 years, I'm sorry to say, man, but 1/3 of those will not be there. In general, obviously. Now we have better techniques, we have a better soft tissue understanding and stuff. But if we talk broadly speaking, that's what the statistics show us. So, and the thing is this: if someone loses their teeth by their 40s, and those teeth were there, let's say, since the person was 10 years old, 12 years old, so only the teeth only lasted 25 or 30 years, how can you expect that the metal screw will last more than that? That has no periodontal ligament to absorb the forces, which is the biggest problem of implants, is that they have no shock absorbing ability. And that's why we start to lose bone loss, early bone loss, because the stress has to go somewhere, it goes to the crestal bone, and it starts to disappear.
For sure. And I think, like you said, when these patients, they've lost all their teeth in 20 years, a lot of times there's a lot of contributing factors that go into the reason why that happened, whether it's smoking, poor oral hygiene habits, whatever it is. Even though patients say like, hey, I'm done smoking, or I'm going to keep my teeth clean now. Once they have a new set of teeth in there, a lot of times these patients fall back to these habits that they've had previously, and there are going to be complications that occur because of those. And that they have the ability to manage those, I think will really further a lot of dentist careers and get to a point where they're like, oh my gosh, all these cases I've done 5 years ago, I need to revise now. I'm not comfortable doing that. If you just get some of these basics, it'll prolong your full arch career, and you'll have a much happier career where you feel like you're going to the library every day instead of going, somewhere you don't want to be.
Preventive dentistry and the revision dentistry is going to be the future in the short, medium term, to avoid these things from happening, to avoid people from getting implants in the first place, which is something that I talk a lot, and you guys are on the WhatsApp group. I talk a lot about this. Should this case be a full arch? Should this case not be a full arch? Can I postpone this? Can I do something to try to avoid removing all the teeth from this person at their 30s, which is quite dramatic, because people, we have to understand that people that we do a full arch in their 30s, they will not die with our implants in the mouth. If they have a normal life expectancy, they will not keep those until they die. And how is this for us? Is this a failure? Is this a personal failure? What do you think? I feel like a bit of a personal failure to doing something that is supposed to be permanent, and it's not. And I know that it's not. The statistics show me that after 15 years, only 2/3 of the implants are there. So I feel like we should be doing way more in the preventive side, and to delay these things a lot. But unfortunately, the healthcare is like, guys, nobody makes money preventing the disease. The money is made treating the disease. And and these, we could talk a lot about this, but this changes the whole perspective that we have on healthcare. Is not to promote health, is to promote the disease. So
it's funny, this is going down a different rabbit hole, but I actually had a dental cleaning this morning, and my hygienist was talking to me about Peter Attia, and he's one of the guys that are on the Huberman podcast a lot, And
I read
one
his
of
book.
his big philosophies in medical school was the lack of preventative care in the United States and the sheer impact of what a lot of these pharmacology departments or like big businesses, right, pharmaceutical companies push, and they're pushing medications that treat these cases when in reality a lot of the people in the United States that have issues like diabetes or overweight or whatever it is could have been cured through preventative measures.
Yep.
But instead
Lifestyle change habits.
exactly,
Yeah.
and
Yeah.
instead are treated with drugs,
Yeah.
and they continue some of these habits.
Yep.
I'm not saying that everybody's like that, but it's very similar to oral care. If you're in your 30s and we can make you last another 10 years or even 20 years prior to getting one of these major treatments done, I think it's really important. And that's something that I know me and Tyler talk a lot about, and we really push patients that are coming in these age groups, unless they're in a position where they're totally not able to be rehabilitated, but we push them to wait before getting this treatment done. The problem is the more and more of these centers that pop up, I see patients that are coming in that are in their early 30s that have teeth that are totally fine, and they're coming as a second opinion from a
With
clinic
a quote
that said
for an Alan.
yeah, right. That
man.
I'm like, what? Like, you are totally fine. Like, you do not need this done in your situation. And the problem is they're just going to turn around and go to the clinic that said, hey, we can do this today.
Yeah.
So it is a major problem.
This
and
is a
it's
major
something
problem. You know that
Yeah.
in some countries here in Europe, you go to jail if you do something like this. The laws in some jurisdictions here are so strict about implant kind of treatments that you lose your license, man. Like this, if it gets proven, the people that will be against the doctor are also doctors from this kind of mindset, the correct mindset, in my opinion, that will prove, because this and this, that this case should not be a full arch. So these doctors have mutilated this mouse, so the consequence is this. And it's usually either suspended license or they banned the guy from practicing in this country again, or you can face criminal charges and end up in jail. It's seriously.
It's no joke.
It's no joke. So I think we are a bit more conservative. I think also, to be honest, in some places maybe too much conservative and try to save what is not possible anymore, or at least in the context of full arch rehabilitation does not make sense to save. But there is a fine line on the sense.
Yeah, for sure.
Yeah,
I mean,
yeah,
I think that definitely is the other side of the equation, because
yeah.
I don't know what the ratio is, but like for every patient that I've seen that was treatment planned to have all their teeth removed and get this done, there's plenty of other patients that I feel like this should have been done a long time ago, and they've wasted money and they've wasted time, and now they've got this insane newfangled treatment in their mouth. I mean, I've seen people that had a mini implant here, a standard implant here. They've got 2 telescopic copings on their natural molars, and it's all this removable upper snap end that never worked.
Oh, man.
And you see all kinds of things where people are just trying for the sake of saving teeth, but then there's this misguided approach towards just save what's there, and it really ends up costing the patient at the end of the day, and they end up getting an all-on-4 eventually, or they just go broke or end up in a denture because they don't have any more to invest. And there's that too. And so it's not just important to know how and when to do this. Well, rather, I already gave that away. It's not just important to know how to do it, but when. And there's times where it's not getting done, but it should, and there's times where it's getting done and it shouldn't. So I think it's so important that even people that don't focus primarily on full arch, that they understand its place just in the full array of what we can do.
Yes, it's one of the most difficult things is to discuss this topic, because something for me can look like one thing. From the easiest way to create a discussion is to show a panoramic X-ray to 10 doctors, because you will find 10 different treatment plans. But I think it's very difficult to make the line where what is correct, what is wise, what starts to be over treatment. It's not easy, and I think more guidelines are needed for this, for the benefit of the patient. Maybe AI will solve the problem. I truly believe AI will be the judge very soon in most non-criminal things. Even civilian things, I believe AI is going to be the judge. There is nothing that is more fair than a computer intelligence to analyze data. So
Yeah. Yeah, we'll see. I feel like the scary thing is that before we're talking about a lot of philosophical ideas, but before any of that gets into actually like make changes, there has to be some serious complications that occur to make things move. And I wish that it was a little bit simpler, but I feel like that no matter what, that's what's going to end up happening. But
Yeah.
I think we've gone through a lot of the philosophical side of things. I'd love to move the conversation into some clinical stuff, and I know we have some questions here for you that we've touched on throughout the beginning of this episode. But I know our listeners really like to talk about some of the basics. And a few questions I have for you, Bernardo, are: what are some simple things that doctors can do to improve their outcomes of their cases over time? And I know we talked a little bit about soft tissue grafting, but I'd like to go into that a little bit. And then I'd love to hear what are some mistakes that you've seen about how people approach full arch cases, and how can they manage those and prevent those to ensure that they have stability over time?
I think the best and the wisest and the cheapest thing to do in the beginning is to find a mentor that is very good clinically, but also very good mentally. And if you find this mentor, try to work with the person, not for the person. Try to shadow the person, or try to go into a course, to this person's course, and try to talk in private. Try to understand how the person thinks, why he's choosing this solution instead of that solution. The clinical, as I said the other minutes ago, the clinical part is the easiest to achieve. To learn something, nowadays you just need to pay. You pay for a book, you pay for a course, you pay to go to a meeting, and you learn. And that's the easiest part. I think the hardest part is the mental part, is to try to understand or try to put your brain function in such a way that you can choose the wisest decision most of the times. What should I do in this case? What makes more sense to do in this case for the benefit of the patient in the majority of the times? I think this is the difficult thing the most difficult thing to understand, to learn, because you don't buy this knowledge. This is something that some people have a natural brain for implantology, to be a handyman, to work with screws, with bolts, to work with an engineering brain. And this is the hardest thing to teach if you don't have a good engineering brain. You can teach all the techniques, all this stuff, but having the right mindset, I think it's the crucial part. And in this regard, for example, for me, it stopped making sense, for example, to do a quad zygo if I can do a custom implant and preserve all the bone of the patient. This is the kind of mindset that I'm trying to explain is, if you have 2 or 3 solutions for the same thing, what things are you putting on the table to make your decision? And I think that the destruction involved should be the first or the second for the benefit of the patient, for example. Then, how long is the surgery going to take? Do I need a general anesthesia? Do I not need general anesthesia? Is the patient going to suffer for a long time, or is it going to be an easy post-op? All these questions that we make, I think, should guide the decision-making process. And we really try to put doctors to think like this, to teach not only techniques, but ways of thinking about things. But what was the second question, Soren? Sorry?
No, I agree with that. I'm just going to give my opinion, and I'll go back to that second question.
Mm-hmm.
I get asked a lot from dentists who are, or maybe, students who are in dental school who are really trying to get into full arch and implants and whatnot. And they're like, hey, I saw that you fast-tracked your path towards implant dentistry. How did you do it? What would you recommend for me? And my response is always the same. I always tell them the most important thing is learning those fundamentals. Learning how to take teeth out, learning how to do these things, because that's how you get these efficiencies. And when you are efficient in the case and you understand the fundamentals of taking teeth out and laying flaps and all of these things that people might overlook because they think that it's rudimentary, understanding the proper protocols for doing that will relieve a lot of these mistakes that people run into when they're rushing removing teeth, or they're rushing laying flaps, and it's causing buccal plate fractures, or different occurrences during the surgery that could have easily been managed just by learning those proper fundamentals.
Yeah.
So
that's what we spend. You certainly, sorry to interrupt you. The master course, the first day, the first almost 5 hours in the morning is just about fundamentals. Even if you already know how to do L14, you will get bombarded with fundamentals in the morning, how to do the flap, where to put the blade, where the incision, why is the incision here, and for example, the vertical releasing incisions, why in this place and not half centimeter posterior. There is a reason for everything. There is a reason, I would say there is actually a reason to do every single thing that we do in a full arch case. That nothing is doing randomly. And absolutely agree with you. The fundamentals, for example, here in Portugal, it's quite common when you go to a dental group, it's like, you want to do implants? Fine. But first, you have to take out all the impacted teeth. You need to prove that you know how to do surgery. And after you prove this, okay, maybe we will start to give you now some simple implants, and then maybe we will give you some full arch cases. But first, you prove you know your stuff in surgery. This was the Cuba time for me. When I was there, it's like, Bernardo, you have 10 impacted lower molars to take, and you have 2 hours for all these patients. And we were numbing them, like to numb one here, one there, one there, one there, and there. And then it was like fabricating cars. And that's how you get good at those things.
Yeah. No, I agree 100%. The second question, Bernardo.
Yeah, fundamentals is the way to go. Before you think about, even before you think about doing a single implant, you need to be very proficient in taking impacted teeth out, at least in my perspective, in doing flaps, in traumatic extractions. You need to be very proficient on this. Only after this, you can start to do the interesting part. But the fundamentals, if you don't have them, that's why I told you in the beginning that I always read the full Peterson book when I was in dental school, and this changed my life. Reading the book over and over and over again, because I knew how to solve a lot of complications, and I have never seen them before. But I already knew how to solve them when the time came. And it's all about fundamentals.
And a lot of that stuff pairs together, right? Like if you start to realize how to solve certain issues that occur, I think it goes for different cases and how to solve different problems throughout the oral cavity. And then everything, as you learn more and more, meshes together to get a clinical suite that you can handle these larger full arch cases.
Yeah.
The second question, what are some simple things that people can do to improve their outcomes for these surgeries over time?
I think one of the hackings that you can do on yourself is start to work with the left hand, and this changed. We forced you.
Yes.
This is something we do at the master course actually, and then in the bootcamp it's like mandatory. We train you to use the left, and this is something that will change your life. And I'm sure that everybody will understand what I'm going to say now. If you are right-handed and you are going to place a tilted implant on the second quadrant, some patients don't open enough. You barely can fit your hand and the contra-angle and the drill, if it's a long one, it's very complicated. Plus, when you work with both hands, your level of symmetry, it's unparalleled. So I think that one of the cool things is start to be ambidextrous. I was not born ambidextrous. I trained myself, and now I write with the left. I play instruments and all this, but I forced myself to learn in the beginning, and this changed me. You asked.
We did the master course after we went the first time. I think one thing I said on that was, if you are going to Bernardo's master course, one thing I'd recommend doing before you go is start brushing your teeth with your left hand. Eat your food with your left hand. Bernardo will give you an extra pat on the back if you get there and you're proficient with doing that with your left hand, and you could actually feel comfortable angling an implant using that left hand. So I agree. Being able to use both hands back and forth when you're doing these cases, it'll make things much easier, and it'll make your cases much more symmetric as you do them.
Yeah. Another thing that I think helps a lot people in the beginning is what I was telling before, is to find a mentor when they work with the guy or shadow the guy, because what will take you 10 years on your own can take 6 months with the right mentor. And no joke, it's really how fast you can progress. And
Someone in,
yeah.
oh, go ahead.
No.
I was just going to say, in my learning, I had a mentor my last year of dental school, and I was fortunate enough to be able to work under him for an entire year. And so shout out Dr. Hikili. He was gracious enough. He had a really large oral surgery background, and for an entire year, he allowed me to do all of his cases, and he assisted for me. And man, what I learned in that year, like you said, would have taken me a decade after school. And you'd be surprised with how many people just in your local community are willing to help teach and willing to help you come and shadow. And before I even cut my first arch, I was in the op for probably over 100 cases, just seeing and watching how people manage complications and workflows and how efficiencies with assistants, what instruments to have. And everybody has like different nuances that they like during these cases. And if you're able to get a really good background of how all of these different things work, you can bring everything together. And that first or second case will be so much easier for you because, you know, like you said, you read the book over and over again. If you're in a mentor's surgical room, seeing it done over and over again, a lot of these problems that you might have right off the bat, you'll be able to manage them so much better.
Yeah. Absolutely. Another thing that I also think that helps a lot, and it was something that in my life I was searching for this always, is to try to learn something from the source or from someone that learned from the source. What I mean was, for example, when I wanted to learn full arch graftless immediate loading, I wanted to learn with Paulo, from Paulo Maló, from the source, to drink from the first bottle that was ever created. And this changes so much to a point because especially nowadays in social media, you see a lot of stuff being promoted with a lot of likes and things like this, very big hype, things that are, for example, just not correct or could be better, or there is no reason to do them if you have something that is perhaps that has a better indication or that can be done with more efficiency, or there is pointless to do this because you are adding something without any benefit. So I think that learning things from the source or close to the source, I think it's a good thing. Not only in full arch, but even in soft tissue management. We have great people that invented the techniques that you can learn from the source. For example, I learned to do bone blocks with Frank Zastro, which became a good friend of mine. And he has a story very similar to mine. He was working with Professor Kouri, for example. And so I was like, okay, I either learn this from Fuad Kouri or I learned this with Frank. And then I went to Frank's. And this was always, my life was always like this. I always wanted to learn the closest from the source as possible, to hear the information and to acquire the knowledge unbiased. Because in dentistry, there is this thing that I don't understand why this happened, which is everyone wants to add a touch of his own on something. Something that has been done for 20 years, I will do it a little different and call it something a little different for no reason. And I think learning stuff where it was born, it's something wise to do for someone that is just starting and is like clueless on the full arch game. I think that these are the three things I would recommend to doctors starting just now. And maybe a fourth one, if you don't mind, which is to keep this critical mind, to be critic of what they hear, of what they read, of what they see on social media, and especially being very critic with their own work. I told you I always photographed all my cases, and the amount of stuff, guys, that I learned in my first years just looking at the pictures, it's invaluable. The suture details, what happens if I start the suture on the buccal versus what happens if I start the suture on the palatal, where to put the incisions. I fill the socket with this bone graft, but there was something missing. How did this turn out in the future? I learned so much taking pictures, macro pictures, not cell phone pictures. That's bullshit. I mean, with this, I will show you.
With the nice DSLR.
This was, I will tell you the story of this. This is a Nikon D7100. This I bought with my first salary. My first salary was all to buy the camera and the lens. More than a decade ago, it's still my camera. And my parents were like, Bernardo, your first salary, you are going to throw all this away into this camera. And I told my dad, this is going to be my biggest CE investment. If I take in proportion what I make this month versus what it costs, this is going to be my most expensive CE program. And it turned out to be one of the best CE that I took was buying the camera.
Yeah, I think proper records when you're doing these cases, it's invaluable to see changes over time in your patients, and you can't do it without good imaging, right? It's easy to have a patient come back for a 2-year follow-up and you don't have a picture of the beginning and just say, oh yeah, that looks good. I think that's working well. But if in reality, if you had a first picture, you could see, oh wow, they actually lost 3 millimeters of keratinized tissue on the buccal of that implant. What did I do in this case that I could have done differently? So I agree 100%. And that's a main reason why I like to, post all my cases and be accountable for those x-rays and everything, because I like to look back on those and say, okay, what did this case look like when I did the surgery? And where is it at now at my follow-up? Did I do something wrong? Was there something that was different than most of my other cases that changed those things?
Are you guys already taking pictures as well?
Yes.
Yeah.
I don't post a lot of my surgical photos in my Instagram because I do have a lot of followers that are patients. And I'm trying to, there's a balance between doctor-facing or patient-facing Instagrams. And I think I will be leaning towards, I'm probably going to start an Instagram account just for my clinic where I post a lot of those before and afters, and then I'm going to post more surgical photos. But I do surgical pictures throughout all of my cases as well. And I think you've probably seen some of those because I post some in our Full Arch Club group chat, and I try to post surgical photos as well. So I agree 100%. I think that's super important.
Yeah. We have a colleague there, a Polish guy. He posts a lot of very detailed pictures, like the implant still in the beginning, then the implant on the middle, then the implant all bone level. But it's
super
very
macro.
Super macro pictures. But I told him when he took the master course, man, if you keep taking these pictures, you will fast forward your career super speedy, because you see your shit in macro ampliation. So, and he's getting quite proficient on that. Yeah.